Okay, thanks for joining us, everyone, for another edition of Discussions in Diagnosis. And I think our guest this morning virtually needs no introduction, but I'm going to give him one anyway. And that's Dr. Peter Pronovost, who is our Chief Quality and Clinical Transformation Officer here at University Hospitals, and also the Veal Distinguished Chair in Leadership and Clinical Transformation. Most notably, I think that he's been a prolific researcher who's pioneered the use of checklists to reduce errors of many different kinds, including catheter-related bloodstream infections. He is also the recipient of a MacArthur Genius Grant in 2008 and was declared one of the 100 most influential people in the world by Time magazine as well. So it's a great honor to have Peter with us here at UH and here this morning as well. Thanks for joining us, Peter.
That's great to be here, Goutham.
So I wanted to talk about a couple of articles you had written, one with a former colleague of mine, Saeed Ibrahim, and also with Jonathan Edlow. But let's talk about the one from a couple years ago, which talks about diagnostic error and disparities in healthcare outcomes. So disparities in healthcare outcomes have been talked about a lot in terms of healthcare access and treatments, but diagnosis itself has received a lot less attention. Can you talk a little bit about the association between diagnostic error and healthcare disparities?
Yeah, sure, Goutham. And this work came about as I was chairing or co-chairing the Society of Improved Diagnosis annual conference and saw that there was virtually nothing discussed about this. But when you started peeling the onion back, there's, just like there are in treatment disparities or outcome disparities, there's a fair bit of data, such as a lot of data on genetic testings are inaccurate because their base populations that were tested on were not diverse enough. Evidence that Black children are less likely to be diagnosed with otitis media, and less diagnosed or more likely to be undertreated for pain or less diagnosed for pain. And so we started seeing that everywhere we looked, there's misdiagnoses. And sometimes, Goutham, the misdiagnoses or the bias is actually embedded into the algorithms that we use to treat people.
Well, that's certainly a serious problem, and you gave us a number of examples across the spectrum of clinical care. So you talked about some of the algorithms that might be biased in of themselves. What are some of the other causes of disparities in diagnosis?
So there's a number of them. One is that the sample populations on which these algorithms were developed weren't diverse enough, and that applies to trials that don't include women or don't have children or don't have people of color, and it puts bias in. Another is the implicit bias in our clinicians that we may not want to be biased, but it is. I'll give you an example, Goutham. We published a paper at my prior institution where we had a protocol for screening for risk for DVT and then appropriate prophylaxis. And what we found at baseline was that people of color were less likely to be screened and less likely to get guideline concordant therapy. Now, the hopeful part of it is when we put an EMR decision support rule, and we had a hard stop, so you had to do that before you could enter your orders, not just performance improved, but the disparity was eliminated. And and that, I think, raises great hope that our Epic investments, that's a lot easier to use decision support tools, could be not just elevating everyone's performance, but elevate or eliminate any disparities that might exist.
Okay, terrific. So in the article with Dr. Ibrahim, and you mentioned Epic just momentarily, but you talk about the promise and pitfalls of artificial intelligence in addressing disparities in diagnostic error. So maybe let's start with the promise of AI. How can AI help us reduce disparities in diagnosis?
So, Goutham, right now, I would say that this diagnosis is probably the perhaps strongest bastion where we rely on heroism of clinicians rather than the design of safe systems. I mean, with the explosion of medical knowledge and subcategories of diseases. So breast cancer isn't one disease, it's probably 15 different diseases. You know, it's completely unrealistic to think that we could keep all those in our brain and that we have the cognitive capacity to make every diagnosis right. And so we bring our biases that have existed. For example, people of color are more tolerant of pain or have higher pain thresholds to that diagnosis the threshold, or they may not be able to pay for something. So AI has the potential to eliminate those and make diagnosis much more accurate. You know, and if you look, Goutham, we're really, really far behind virtually every other safe industry in our use of AI. I mean, if you look at flight, 98 or 99% of it is all AI. The pilot intervenes very little because it's known that it's safer. You know, even our cars now, most of them have, well, not self-driving, but some anti-crash features that, you know, are designed to avoid it. And so it's not surprising. And there's other reasons, but AI or the lack of it contributes to it, where, you know, not only are our rates of harm log orders more than other industries, we're also the only industry that's risky that our slope is flat. We haven't made progress, at least according to, I'm sure you saw that recent New England Journal study from Massachusetts showing 1 in 4 patients are harmed. So I think we could accelerate. The other problem with AI, Goutham, is we don't have a standard approach for reporting the performance of AI before we use it. And let me say what that is. You know, most of the AI models that we deployed at UH, and we're changing that, we are making standard performance criteria. We don't require the vendors to say, what data set and variables did you include in your model? What potential biases might have been in that model? How did it perform on that data set? And how does it perform in our real world? And, you know, and I'll give you an example. We were putting in a AI model with a technology that had who needs a palliative care consult. And when I asked the vendors for that, they looked at me like I was cross-eyed and almost patronizing, saying, oh, you know, it's really sophisticated statistics, you know, and you just trust us, it works. I was like, well, hey, I get it. I have a PhD in epi and clinical research. Right. I can get the statistics, show me. And of course they didn't have it. And when we put it in, it performed no different than us clinicians saying 3 variables. The patient over 80, do they have cancer? And I forget what the third variable was, but there was no difference. The other piece, Goutham, about biases that baked into it is really also problematic. And many of you may have seen this came to light with looking at the GFR formulas, right, where for decades, the GFR formulas underdiagnosed
chronic kidney disease
in people of color, right? I mean, and systematically, so they were less likely to get therapies. They were less likely to get therapies that slowed progression of disease. They were less likely to get transplant because the algorithms lowered what their expected threshold was. And that was an enormous debate. I mean, even just a year ago, where right, there was discussion of, well, no, is this biological or you know, like, and we had that discussion here. For those of you who are interested, I hope you'll know we changed our formulas to remove race in our lab estimates. So if you're using it, you could be confident that it's not biased.
Right. Well, thank you. Yeah, I think the idea of the diagnostician as a hero kind of resonates with me. I mean, as a primary care doc, I mean, when somebody comes to you and says, well, the other doc couldn't figure it out, I'm hoping you can do it. And of course, it becomes a very individualistic thing. So I can see a little bit of reluctance to rely on AI in that circumstance as well. So let's turn to the other article that's more recent that you wrote with Jonathan Edlow from Harvard. And it deals with this very specific setting, and that's the emergency department. And one of the solutions you spoke about was increased transparency of diagnostic error, for example, in the emergency room. Can you talk a little bit more about that?
Yes, sure, Gautam. And let me just go back to your last comment
Yeah.
about how it feels like heroism and as a family
Mhm.
practice physician, because this paper, and like most diagnostic errors papers that show the scope is large, cause a firestorm of resistance amongst clinicians. And some of it might be methodological, but what's deeper in this is accurate diagnosis is so tightly linked to our self-identity as a physician or as a provider. I mean, we pride ourselves when we do it. We believe that's what we're trained for. That's a differentiator that we bring to the care team. And so if anything calls into question that about our ability to do that, it is highly pushed back against.
Oh,
now,
yeah.
this paper, just for the people who haven't seen it, suggested that over 350,000 people die each year from diagnostic errors, just in emergency departments alone.
Mhm.
But I think, one point that they didn't highlight was that the error rate in the ER was actually no different than was found in primary care or what it is in the emergency department. And what it suggests is this is a ubiquitous problem. Yes, they studied the ER, but as all of us know, it's across the board. What I said was about transparency is because we lack practical, valid measures of misdiagnosis. And Gautam, I know you have grants and are working on this important topic. Misdiagnosis is almost entirely invisible. I mean, we know, as you may have heard me talking about, a lot of our defects in value are visible, but the misdiagnosis are probably the most problematic because of the lack of measures. It stalls our ability to learn and improve because you often don't get feedback, or you get feedback very much in the future. And so that cycle of reflecting on what you did, redesigning processes or closing gaps, and then reducing those risks doesn't exist. And my hope, and there's a lot of work here and nationally on this, is to have a valid set of diagnostic process error measures or even diagnosis error measures, so that it becomes no different than, are you using a checklist for infections and have you reduced your infection rates?
Right. So just another quality score, basically, like the ones we have for treatments.
Exactly right.
Great. Terrific. So in the same paper, you set an ambitious target of a 50% reduction in diagnostic deaths and related disabilities within 5 years in that particular setting, the emergency room setting. How do you believe we can get there?
Yeah, Gautam, great question. And that number, it may seem ambitious or perhaps delusional to some, but when you study safe industries, the automobile, train, airline, nuclear, inland firefighters, they have all had, literally over 99%, some several fold reductions in their harm rates over time. And they did it by several specific things. One is, and probably most importantly, they realized it's a system issue, not a personal performance issue. Mm-hmm. So, it's very rare errors are some bad intentioned provider or operator. It's the system within which they work. So they focused on that. They did more sector-wide solutions. And there's a White House presidential task force now that I'm honored to be on, the President's Council for Science and Technology, that is indeed recommending sector-wide solutions. I mean, because right now, our approach to safety, it's kind of delusional, is every unit do a PDSA cycle, right? And that's probably good for some things, but it's not going to solve diagnostic error problems, as you could know, but we're moving in that. Okay. And then third is they approach it with system solutions that leverage technologies. And in our case, that is likely going to be better diagnostics, including biomarkers and AI that would allow us to more accurately diagnose. And we're seeing this, grow exponentially in pathology, in radiology, in dermatology, and perhaps not surprisingly, things where we have images, because computer vision, I think, is really advanced, and it's, I don't want to say, a simpler process than the clinical reasoning of help me understand sepsis. But we have some recent studies showing that an AI model to diagnose sepsis, a study that I published the original one on, is much, much more accurate. Indeed, like well over 89% for predicting who's going to get sick from sepsis. And so I think these things are exploding. What I don't think will work, Goutham, if it's let 1,000 flowers bloom. And so, we don't have some standards before we deploy AI performance, or at least transparency of how they perform. And most importantly, that we create a learning system where we're, constantly saying what's working and what's not working.
Right.
I don't think, Goutham, penalties from, if we do make measures of diagnosis, are going to be the way to go. The data on financial incentives for quality is pretty weak, that it doesn't seem to have a big impact. I think it's going to be creating these sector-wide learning systems.
That's really exciting. Yeah. And congratulations for being on the President's Council, and look forward to seeing that work. So we've got a couple of minutes left, Peter. So I'm going to throw this open to our audience. We've got about 25 people on, to see if they've got any questions or comments to make. Please make sure to unmute your phones. I'm going to scroll through here.
Hi, good morning, everybody. Mary Delansky. Hi,
hey, Mary.
Peter.
Hey,
yeah,
Mary.
Hi, great discussion. My question is, where do you see like the interprofessional kind of contributions to this topic from the systems perspective, or where can we think of solutions in that realm?
Before you answer, Peter, I just want, Mary is a co-PI on our diagnostic center grant, as you know, together with you and me and Dr. Marlene Miller. So we actually had a number of discussions about team-based approaches to diagnosis, including nurses. So that's kind of the context that I think she's referring to.
Yeah, Mary, fantastic. And the science of decision-making, less so in diagnostic area, but profound in political science, in aviation, and some in healthcare, says the team has a profound impact on making the right decision, or in this case, diagnoses. And what I would remind this audience, or perhaps plea with them, is that there's two explicit and concrete things you can do tomorrow to make better diagnoses. The first is teams make better diagnosis when there's diverse and independent input. Diverse and independent input. So what does that mean? That means get anybody who has a voice to say what they think is going on. And so that's nurses, it's the patient, it's their family, it's consultants, it's the primary care or the primary attending physician, it's a respiratory therapist, a nutritionist. But the independent is key, because that requires that team sense a culture where it's safe to speak up, that everybody says, okay, I'm empowered. We were working, when we published a paper with some anthropologists looking at rounds in the ICU, because rounds, if done well, create that structure. But so often the culture is that some people feel that if they don't have the right degree after their name, that they can't speak up, or that they need to have a certain strength of evidence before they say something, rather than just sharing what we're worried about. So those of you who lead rounds, it's really important that you create that safe culture by explicitly asking for input. What do you think's the diagnosis? What do do you think this right? The second thing that augments great decision makers, and in this case, diagnosis, is they build in pause points when you get divergent information. So let me explain what that means. We often make rounds, and again, if done well, there's brainstorming and throwing ideas, and hopefully, which is one of the reasons why we developed the daily goals checklist, we get convergent to say, okay, here's what we think the diagnosis is, here's the cure plan for the day. But as time goes on, you might get hints of data that question that initial diagnosis or thought, like, that doesn't really fit what I'm thinking of, or I thought they had sepsis, but their minute ventilation's really, really low. They don't look so stressed. I'm not, maybe this is, thyroid disease. So anyways, the great diagnostic people, when they see disconfirming information, build in a pause point and a huddle. That is, they say, okay, the story doesn't look like we originally thought. Let's pull that diverse team together right now and say, okay, what's going on? Can we confirm this? And Mary, or maybe this is my bias as an ICU, but we have so many needless deaths because we don't build those pause points, right? Either for whatever reasons, for hubris, or they can't get off the tunnel vision. No, I made this plan. This is the way it's going. And clinicians speaking up, get the whole interprofessional team saying, no, we need what I call a bedside huddle. We need to get a huddle to say what's going on. Or more important, more often, Mary, it's a specialist and an attending physician disagreeing, or two services, and about what needs to happen. And they get into a chart war or a text war, as opposed to saying, hey, we don't know what's going on, but something's clearly wrong with our diagnosis. Let's be humble and curious enough and compassionate to each other to say, call a bedside huddle, bring people together, and let's recreate that setting for wise decision-making with diverse and independent input.
Thanks for your
Great,
question, Mary. Thanks, Peter.
Thank
Any additional questions before we wrap up?
Hey, Goutham, it's Jessica. I'm actually
Jessica.
working. Hey, and
Good
hey,
morning.
Peter. Hey, everybody.
Hey,
Yeah, I'm
Jess.
in the ED right now. So one of the things that really resonates is, the team building and this need for like the relational coordination between providers and care team members. And it's one of the things that as I'm preparing for this voice of the provider for AHUJA for next week, and we're putting together some slides on burnout and what we can do to really talk about patient and provider engagement. And one of the things that really carries through is this need to focus on building teams and having that relational coordination and really focusing on respect between team members. And just wondering if you have thoughts on, where to focus on in terms of trying to drive the whole system towards that team-based approach, because it isn't necessarily shown in our UH core values or in our mission,
Right.
that teamwork, that prioritization for this cross-departmental interdisciplinary collaboration.
Yeah, Jess, I think you're right. It's not shown in, perhaps one way, or at least the way when I'm speaking to providers directly about this, I, allude to say, if you play soccer or lacrosse and you get a penalty, you put a person in the penalty box and you quote, play man down, right? And you'd never voluntarily play that way because you're going to lose. Like, it's just, you're handicapped. And then say, we play person down every day in healthcare because we don't invite every member of the team to contribute. And so not only will you make better decisions for your patients and your outcomes, there's great data that it's more joyful for you, so it reduces burnout. It also, ironically, Jess, increases your perception of that you have a normal workload. In other words, if you take two teams and one has really high teamwork and one has really low, the high teamwork's perception of workload burden is dramatically lower. And I mean, you probably see that in the ED, or any time critical situations when you're humming, like the high workload, you can deal with it. But when you're fighting and there's political backfighting, and I think what I would probably ask them to do is for them to initiate that team building, to be more solicitous of ensuring nurses are on rounds, or ensuring people speak up, or something they could do to help with that relational coordination, because it doesn't happen by chance. And it's as simple as asking humble questions, where they're just saying, hey, what do you think? I'm not sure what's going on here. Could you share your advice? You're really experienced. And so I don't know if that resonates, Jess, but I love to talk further with you about this, because I think it's a huge opportunity at UH. You know, this was a topic I talked about for Safety Week, because I think we're really advanced now in getting checklists and the need for protocols, but the relational coordination part is still underdeveloped as both a core value and a practice at UH.
Great.
Yeah, agreed.
Great question, Jess. Okay, we are officially out of time, guys. Thank you so much, Peter, for joining us this morning. It was a great discussion. Thanks to everyone for joining us as well, and have a wonderful rest of the day and a wonderful weekend. Take care, everyone.
Thanks, Gautham.
Thank you.
Bye-bye.